Do we have any further questions, please, for either of my colleagues or myself, for that matter? Yes, one in the middle, please. Thank you, sir.
Thank you. Dr. Bill Chatto, consultant microbiologist, London. I have two questions. One is Professor Jarman, that recent survey suggested that a significant problem with mortality in NHS hospitals is failure to detect pneumonia and septicemia. And I wondered whether it is very important to teach not only the junior doctors and also the nurses who are very, very good in detecting patients going off in order to reduce this type of problem. Because as doctors, we have lost our clinical acumen. We depend mostly, if not entirely, on expensive toys. So unless pneumonia is diagnosed, by sending the patient to a particular department, we decide not to treat them, which I think is not quite right. And the second question is to Professor Mark, and that is, what I find more and more, that the junior doctors and some of the consultants, they are treating the antibiotic guidelines rather than the patient. Your patient is right in front of you. You will have to take a proper clinical evaluation before you decide which antibiotic to be used. But whatever is written in the guideline, you prescribe, irrespective of the patient's other clinical problems or comorbidities. Thank you.
Professor Jarman first.
Well, I agree with you about clinical acumen and so on. The best predictors of low mortality are more hospital doctors per bed, more GPs per 1,000 population, and a higher percentage of trained nurses, and a lower percentage of senior managers. And I think things have changed in which the medical profession has gradually become emasculated over a period of time. If any hospital doctor tries to draw attention to problems in the hospital, having gone through all the various processes, and then feels they have to go further, and draws attention to it via the media, becomes a whistleblower, then that doctor is dismissed. If a manager wishes to get rid of a doctor, all they need to do is report them to the GMC for anything. The GMC then finds that this was a false report, nothing wrong. The doctor may be dismissed. Now, the manager who does that report, nothing happens. Managers have no ethical standards equivalent to doctors. The doctor who has done nothing wrong but has been reported to the GMC will never work again in the monopoly National Health Service. If they're found to have been at an employment tribunal wrongly dismissed, to get compensation for their costs, which can be up to £1 million, cases I've heard, and breaking up of families, and really, I mean, there are something like 56 doctors have died waiting for decisions from the GMC. They will be required to sign a gagging clause to state that they will not disclose what was wrong. To me, that is an arrangement that we have got between managers and doctors in the health service, which is completely contradictory to any good quality care for patients. So I agree with you, and I believe that clinical acumen is essential, but I'll pass to the other.
I couldn't agree more with what Professor Jarman says, actually. The difficulty at the moment for anybody who works within the NHS is that I think all of us who work in it want to see it grow and prosper and continue to be what was set out to achieve in 1948. And I, like people here have dedicated, perhaps a strong way to put it, I feel I've dedicated my life to it, and it's something I want to do until the end of my career. The difficulty I think that has come through is that as professionals, it's not just doctors, I think nurses as well actually fall into this, and other professional groups, that they really aren't able to speak openly now. Funnily enough, actually, with QHA, one of the things we insist on is a powerful, all-singing, all-dancing whistleblower policy, which will be supported and enforced within an organisation. And they managed to do that in Hong Kong and Singapore and Dubai, so, you know, we should be able to manage it in the United Kingdom. I can't really add anything to that.
Could I address your point on multimorbidity, which is very well made? We are about to embark on a program of guidance on the management of multimorbidity. The first of these is actually a piece of social care guidance on the social care of people who have more than one medical condition. It's being scoped at the moment. But I think the general rule when faced with someone with a number of clinical problems is to ask the question, what is this patient going to die from first? And to deal with that. Now, sometimes that will be an acute infection, but often it won't be. Sadly, as you hint, it's not only commissioning organisations that can't think anymore. It applies to lots of clinicians as well.
Well, I'm just going to emphasise the importance of the nursing side of things and having trained nurses, then nothing more than that.
I agree with that. Nurses are traditionally, in our healthcare culture, the guardians of patients. And I think that anything that can be done to maintain that relationship between nurses and patients is something we should all fight tooth and nail for. Any nurses in the audience care to comment on that? Yes, there's one. Ah, yes, I can see two.
Just pointing out that we were in the audience, really. No, we would agree with you. And we're both in infection control. I'm a deputy DIPSI in East Kent Hospitals, and certainly, you know, I think we should do more to promote the value of nursing, because unfortunately we see it being eroded. More and more healthcare assistants are coming in. You know, it's all about finances, I think, but I think we have to fight to maintain, you know, what we've had over the years and to promote it and see and recognise the value.
Yes. Would you care to endorse that?
I'll just echo what my colleague have just said. I'm in the south of England at the end of my professional career, and I feel that I have been privileged to have worked in the NHS, and I am wondering and worrying for the future of the NHS.
Mm-hmm. Can I just say here, I think there is a kind of political crossroads that we're at in the United Kingdom at the moment, and Professor John will undoubtedly correct me if I'm wrong. I think we spend something like 8.2% of the GDP in the UK on healthcare.
I think it's got a bit nearer to 9, actually.
Yeah. But it's quite a bit less than they do in Germany or France or a number of other countries.
we're lower than the OECD average. We did go up a bit, particularly in terms of sort of doctors per thousand population. I think we're something like 40% below the average.
Yes.
And of course, that, as I say, that's the best predictor of low death rates.
Indeed. So, you know, the decision really at, I suppose, the highest political levels is, and I suppose based upon what the electorate want, is would they like to invest some of their country's wealth in healthcare? You know, it seems fairly simple. I imagine it's much more complicated than that when you try to bring it to, you know, what I would say is that in many parts of the world, that 12 or 14% doesn't just come from a government, you know, from a state sector. It comes also from a private sector as well. They talk about the USA spending, what, about 20% or something close to it now. But most of that will be private sector money.
I think it's something like 18% of the GDP.
It's pretty high.
They spend a lot, maybe something like 2.5 times what we spend per person.
Absolutely.
On the other hand, they seem to, from my figures, seem to get a lower adjusted death rate in hospital of the people who are able to be admitted.
Indeed.
And I think we do have to decide whether we want a better healthcare, but I think there are some changes that could be made which wouldn't cost anything, such as allowing clinicians and patients, amazingly, to have more say in the way the NHS runs. I mean, look at the boards of hospitals. I mean, they seem to be chosen for their business acumen and their inability to question what the executive are doing. You look at mid-staffs.
Yes. Can I just say, motivation, how important is that to good infection prevention and control? Anybody care to comment, or there's other questions? Yes, the question over there, if you could right, oh, hands going up all over the place.
I'm a patient champion, safety champion, as well as a head of infection control in London. I won't say where. What I'd like to say is to pick up on Professor Jarman saying about the whistleblowing and the openness in the NHS. I think that we should really, if we are serious about the duty of candor, we should really not just have a tick box for supporting whistleblowers. We should really make sure that they are truly supported, and those who try to close it down should be prosecuted, basically, if we are keen on making sure that the service is safe for patients.
There is this duty of candor, which Robert Francis has recommended. Don Berwick said that, okay for a duty of candor, but there shouldn't be prosecutions if the clinician has tried genuinely to do something about it, that there should be no prosecutions in those cases. I mean, if you look at, for instance, what has happened with regarding Julian Asprey, the diabetic at Mid-Staffs, now the hospital has now admitted that it was wrong. It was last night, it was on the news. I mean, it was just a young woman who actually wasn't very good at following instructions and things, and she was diabetic, insulin-dependent diabetic, and wasn't given the drugs for 6 days. Now, that's going to go to the High Court. The Prime Minister said that there is a lot of information available, and the police could be involved. The police are involved in Morecambe Bay already. I've already given a statement to Morecambe Bay Trust with regard to the case of the son of James Titcombe. We'd actually sent a mortality alert to the Trust regarding septicemia a few months before his son died of septicemia. And I think once the police get involved in things, it could possibly have an effect on reducing the ability of people to speak out. On the other hand, it could have the opposite effect, in which if managers, and don't forget, the centre of the NHS has stated that they're going to have, or the chief exec is going to have, what is, in his own words, Stalinist central control from the centre over the managers. If that happens, it could be that that would be an illegal action. And once you get the police involved, they can go into computers and look to see all that's on that computer, because as you know, you can get what's in a computer way back for years. And they can see the emails that took place between people in organising what happened at the time coming up, for instance, to the Mid-Staffs in 2007. I think it's quite possible that we will find out much more about what happened in Mid-Staffs in future. But I think the essential thing, and I agree with what Don Berwick said in his report to the Prime Minister, which is that we should encourage clinicians of all types to draw attention to problems within a trust. The trust they have to live within their allocated resources. You can argue about the formula, but what they get, they have to live within it. But having got that, their main job should be quality of care, not just talking about quality of care, actual quality of care. Yeah. And silencing clinicians is unacceptable in my opinion.
Thank you, Professor Jarman. I can see clear clinical signs of caffeine deficiency in front of me. Can I thank... I've got them at the moment. I'll demonstrate them physically, Brian. Can I thank two splendid speakers this morning, and can you show your thanks, please? And thank you for being such a good, contributing and lively interactive audience. See you later. Thank you very much.